Okay, hello guys. Today we are going to learn about acute complication of type 1 diabetes mellitus, which is also known as DKA, diabetic ketoacidosis. Now, how can we define that the patient has diabetic ketoacidosis? First, we will check the patient capillary blood glucose level, which will be above 250 mg per deciliter. And if we go for the AVBG, we will see an high anion gap metabolic acidosis. This is a metabolic disorder, so there will be high amount of H plus in the body, which will consume the HCO3 and have high anion gap metabolic acidosis. Now, why high anion gap? We will learn this further. Diabetic ketoacidosis is a insulinopenia state, means the patient is deficit of insulin. Patient does not have any insulin, is characterized by type 1 diabetes mellitus. But why this patient is developing now ketoacidosis? Ketoacidosis is developed because in diabetic ketoacidosis there is less insulin but increase of counter-regulatory hormone. Now why these counter-regulatory hormones, which are glucagon, growth hormone and cortisol, are elevated in DKA? These are elevated because of simply reason are some triggers. Now we will learn about this trigger later on. Now what does this counter-regulatory hormones, glucagon, growth hormone and cortisol are doing? They will signal to the liver producing more blood glucose. Now how? Biochemical pathways like gluconeogenesis, glycogenolysis will contribute to the higher level blood glucose. And then on adipose side, there will be lipolysis, release of free fatty acid, and that free fatty acid will go into biochemical pathways and release ketones. Now these ketones are acetoacetate and beta hydroxybutyrate, and this all are anion. So there is an increased anion in decay. So this is why this condition is also characterized by high anion gap metabolic acidosis, in short, HAGMA. Now there is increased glucose, so there will be some features of hyperglycemia and acidosis together. Now, what are the precipitating factor that increases counter-regulatory hormones? Now, let's you have a patient in your emergency department that is taking insulin but has forgotten the insulin because her mother is going to administer the insulin to his son. The son, so marriage, there is a marriage in the house. Mother is busy cooking and doing stuff and handling relatives and is not giving insulin to his son. Now son is poor compliant patient. So missed insulin dose can trigger DKA. In US there are insulin pump. They can malfunction. Infection like pneumonia, UTI, urinary tract infection, gastroenteritis, and generalized sepsis are high metabolic demanding state. When the demand of O2 is high, demand of ATP is high, you will need more glucose. And that's where the counter-regulatory hormone rises and will lead to decay. Now, most important part is whenever there is decay, people just jump to diagnosis of decay and think we have done with the diagnosis. Give insulin, give fluid, and the treatment is over. No. To know the precipitating factors is very important. If the precipitating factors are infarction, where in cerebrovascular accident like stroke, severe stroke. ACS, acute coronary syndrome, means myocardial infarction, heart attack, mesenteric ischemia in abdomen, or peripheral vascular diseases. Now, another important part is, which is also the differential diagnosis for the DKA and simultaneously present precipitating factor for DKA is pancreatitis, and you will differentiate it from serum lipase elevation by threefold. Okay? And pregnancy can also trigger DKA. Why? Pregnancy is a high demand state of metabolism. So these are all the precipitating factors: overcompliance, missed insulin dose, insulin pump malfunction, infection, infarction, pancreatitis, and pregnancy. Infarction produces inflammation and body that's lead to high metabolic demand. That's why they cause diabetic ketoacidosis. Now, what are the clinical features, symptoms? Nausea and vomiting, thirst and polyuria, abdominal pain, shortness of breath. So the patient, what you will see is the heart rate is above 100, tachycardia. Patient is dehydrated. Patient have low BP, hypotension, tachypnea. Patient is breathing fast. Patient has Kussmaul respiration. What is Kussmaul respiration? Patient has a fruity odor coming out of mouth. Patient is in respiratory distress. When you palpate the abdomen is tender. Also seen in acute pancreatitis and surgical abdomen like acute appendicitis or renal colic. Patient will have lethargy, cerebral edema, or possibly coma. Now, what are the mechanisms of these clinical features? What is happening in this chap body that will lead to all this havoc in the symptoms? So we will divide the mechanism into two stages: hyperglycemia, increased capillary blood glucose level or body blood glucose level, or increase in counter-regulatory hormones. We all know higher blood glucose level will lead to increased osmolarity in body. So there will be increased osmotic diuresis, which will cause polyuria, and that will also increase thirst in the body, means polydipsia. Polyuria will create a dehydrated state, and high blood glucose level will cause high blood osmolarity. So the blood will shift from intracellular to extracellular compartment, which are blood vessels. So there is an intracellular hypovolemia, which will also lead to thirst. There will be lethargy because that is a symptom of high blood glucose. And when there are counter-regulatory hormones which are present in blood, there will be high ketones, which are acetoacetate. Acetoacetate will convert into acetones. Thereby, there will be a serum rise in acetone, which you will see in blood workup. And when this acetone is expired out through lungs, that acetone will give the fruity odor, which is characteristic of AHA, which is known as Kussmaul respiration or Kussmaul's breathing. Now, this acetone is an anion which will obviously rise in blood and will give to the high anion gap metabolic acidosis. So, there is an acidosis, so obviously there is a pH down. For that compensation, bicarb will be used, and bicarb is down. CO2 will increase, that will cause metabolic acidosis. Patient will hyperventilate to release all those excess CO2 out. That's why people will have tachypnea. And in that tachypnea, there will be acetone that will give the fruity odor that also leads to small breathing. Now, metabolic acidosis, hydrogen ions are high, protons are high. That will also cause extracellular shift of potassium That's why there will be a characteristic intracellular potassium depletion, hypokalemia, but extracellularly potassium can be normal or falsely elevated, but the patient is in potassium deficit. So workup, what you will order from laboratory? You will do a CBC, CRP, serum electrolyte, RBC, HbA1c to see patient is how much is having average sugar level high, and to give insulin, you need to know that how much patient is in insulin resistance. Okay, you will order the URM for septic focal, and you read ketones to confirm your diagnosis of ketoacidosis. But if urine ketone enough, no, you will need serum acetone or serum beta hydroxybutyrate. Serum beta hydroxybutyrate is more specific because it is not lost in breathing. Acetone is lost. So beta hydroxybutyrate is more specific. You will do a USG abdomen pelvis for knowing septic foci, X-ray for pneumonia. You can do ABG, but ABG is PO2, which you don't require here. But if the patient is just having simultaneously comorbidity like ARDS or pneumonia, we can do ABG. But if you don't have ABG services available, ABG is okay because there will be a pH down in VBG, HCO3 down, and there will be high anion gap because there are elevated anion in our body. So you will do an ECG to rule out acute coronary syndrome, myocardial infarction, or to give insulin, you need to check your potassium level so you can get an idea of hypokalemia or hyperkalemia from ECG. You will do a tropi D-dimer, tropi for MI again, D-dimer for any hypercoagulable state. Okay. So now, the first to diagnosis and differentiate, you will need to find out the precipitating factor and then do the treatment. So quickly, a note on acute pancreatitis or surgical abdomen acute appendicitis. Do amylase lipase differentiate it from acute pancreatitis? If it is high, it can be the trigger or it can be also lead to misdiagnosis. Now, what is the management? There are 7 steps in management. First, if the patient is not breathing, airway, breathing, circulation should be first checked. ABCD protocol should be done. If the patient is stable, if breathing is maintained, then there is fluid management. This is the main treatment for DKA, fluid management. Proper fluid management leads to excellent recovery in patient. Excellent recovery in patient. Then check the potassium. If it is hypokalemic, correct the hypokalemia. If it's hyperkalemia, correct the hyperkalemia. Then and then only start insulin. If there is a sodium abnormality, please correct it and then do the treatment. Generally, bicarbonate is not given, not advised, not advised. Only if insulin is given properly, then and then only acidosis will begin. Target of management will be reversible of metabolic acidosis and closure of anion gap. Insulin will be given 0.1 unit per kg bolus IV and then in infusion form. Okay. Patient stabilizes is our goal. Shift to subcutaneous insulin regimen. Educate to improve compliance. Fluid management depends on age, weight, hemodynamics of the patient or comorbidities. First of all, we know that it is an intravascular volume